Hello, my name is Benjamin Kent and I'll be presenting our paper on COVID-19's impact on North Fracture mortality, a region-wise case control study within the Southwest. I'd certainly like to thank my co-authors on this paper. So, why did we do it? It was in response to the COVID surge paper published in The Lancet, which had 1,100 patients, predominantly under emergency care. This covered 235 hospitals. They reported a 30-day mortality rate of 23.8%. COVID positive swabs were taken in 26.1% of patients. However, there was no control, no standardized mortality, and comparing this to normal orthopaedic practice was difficult, and it suggested a mortality rate of approximately 28.8%. So, we did a retrospective review of the National Hip Fracture Database across our 5 sites. We had local registrar leads and consultants in each hospital. Data was collected and fed back to the lead within 1 week. Inclusion: we included all neck of femur patients admitted in either year of the dates shown. Data collected included 30-day mortality rates, COVID status up to and including 30 days post-operatively, in line with the COVID surge paper, time from diagnosis to surgery, fracture pattern, operation, and patient demographics. This is a slide from the ONS showing our COVID positive rates at this time. So our results. Unlike general trauma, fragility fractures did not decrease during the COVID pandemic. We had 463 patients in 2019 over this time and 448 patients over the same time this year. There was no statistical difference between the age, sex, ASA, pre-morbidity, resident pre or post-admission, and fracture classifications. These are the demographics shown. So our typical patient was about 85 years old, female, ASA 3, was previously freely mobile without any aids, lived in their own home, and suffered an intracapsular fracture. So for the results, our mortality increased by 0.88%. However, this is well within our standard deviation within the region over the last 5 years of 1.08% and did not approach significance with the p-value shown. Patients, on the whole, did not contract COVID and had a 98.25% negative rate either pre or 30 days post-operatively. We had 14 cases, 5 of which contracted COVID pre-operation and had a 0% mortality, 9 post-operation and had a 33% mortality, i.e. 3 patients unfortunately passed away. The overall mortality was 21.43% if a patient had a concomitant case of COVID and a neck of femur fracture. Time to operation significantly reduced over this time by 1.9 hours, and this was primarily due to a reduction in the patients waiting over 36 hours from diagnosis to operation, as can be seen on the right. This is demonstrated clearly on these graphs, with a significant reduction in patients towards the right of both graphs. So in conclusion, with low community prevalence, there is no significant effect on mortality. However, patients contracting COVID were at a much higher risk, as would be expected. This was in line with the COVID surge paper, with a mortality predicted somewhere between 20 to 30%. Prevalence in hip fractures remained the same despite the COVID pandemic. The study supported the safe surgical treatment of hip fractures despite the COVID pandemic. I'd be happy to take any questions or comments. My email address and Twitter handle are above.